Hey everybody, thanks for being with us today. Thanks for joining us. I know this is the first day of the AAP, and so actually this is corporate forum time going on right now. So for those of you who decided to come and spend an hour with us, that's great, and I hope you find it to be worthwhile. As I'm trying to develop a pattern for this, at least the pattern is that we're going to be doing this, except for Thanksgiving week, we're going to be doing it every Friday at noon Eastern time. So at least it'll be lunch hour for some of you. We've got the continuing education credit taken care of. So we thank the Oral Reconstruction Foundation for that. And that essentially means I look at the list, I see who's attended for most of the session, I send that list to Oral Reconstruction Foundation, and Allison is kind enough to send out this CEU to you, about 4 or 5 days later, something like that. So good. So it's been, by the way, for the AAP, for those of you who are periodontists, remembers the AAP, the AAIP, which is the IDS, we have a room next, a virtual room, next Saturday at 4:45. We'll do a brief presentation about not treatment planning, because treatment planning is what we do here. We'll talk about some of the things that IDS members get and why it may be beneficial to be a member of the IDS, but it's not just going to be a sales pitch. I never do just a sales pitch. I'm going to provide something of benefit to you. Danielle will probably be along with me. So we'll do that together. We'll talk about what's been going on that's been successful, particularly when she goes to offices and is doing consulting, because we found some things that when we go to offices, we presume one thing, we go to offices and we find something else. And those somethings else usually provides you with some valuable information too. So yes, it'll be valuable information, brief sales pitch, and that's what we'll be doing it at 4:45. Don't stay for the sales pitch if you don't want to. I guarantee you the information we're going to give you is going to be valuable. So that's next Saturday, whatever that is, 14th at 4:45 p.m. And that is Eastern time. I think. I think it's 4:40. Anyway, we'll be back together next Friday in case you want to know. And for those of you who are on the IDS list, and if you're attending this, you're on the IDS list. If this is your first time, you'll be on the IDS list as long as you've registered. And the only way you'd come on here is to be registered only. So it's been an interesting week. Lots of new patients. Last week was a record for a while. 32 new patients. 32 new patients called and scheduled last week. And that is, for those of you saying, hey, I'm on the fence. I'm not sure whether I want to independently market yet. Yeah, well, you need some tools in order to be able to independently market. That's why we've got the organization. But yeah, there are plenty of people looking for an expert, who are looking for comprehensive treatment planning. And for those of you who aren't doing comprehensive treatment planning on every patient, why not? Unless you provide them with all of the opportunities that dentistry can provide for the patient. And I'm not just talking about perio. I'm talking about dentistry that can provide for the patient. How will the patient ever know? How will the patient ever increase his quality or her quality of life? Smile, chew, be free of pain, have breath that doesn't stink. That's the 4 reasons. But look at the ancillary reasons. Look at the health benefits that there are to getting diseases under control, getting infections under control. So if you're not providing a comprehensive treatment plan to every single patient, or if you're prejudging your patient saying, well, they don't want that, or you're prejudging the patient saying, well, the general dentist didn't ask for that, that's going to what? It's going to put the patient in an adverse position. The patient didn't know, the patient never heard, and then they end up coming to somebody like me later on when they could have come to you before they came to me, because I'm providing them with answers they hadn't heard before. And that's the purpose of these treatment planning sessions. So yeah, we're going to give you a few tools. We're going to give you something new. I'm going to try a new gadget on my phone and see if I can get it to communicate with you. And I'm going to show you some things that hopefully are going to be different. I may overwhelm you today. That's okay. Take 1 or 2 what you consider pearls, and I hope I'm giving you some pearls by your attending here. And use them for yourself and use them for your patients and try them out and tweak them. If they don't work out quite as well as you want them to, well, send me an email, let me know, and in the next treatment planning session, I'll answer that question. And so we'll get that worked out. And by the way, if you want to ask questions today, just push the Q&A box. If you have a place to raise your hand, I don't have a chat enabled, but I have a place to raise your hand. I'll even, I'll even answer the question live if you have some. So just raise your hand and I'll try to call on you. So in the meantime, let's take a look at some things that that I hope is going to help you today. So let's take a look at our case. Is there anything else? Oh, yeah. I want to tell you one story. One other story before I tell you the rest of the story. So let me get this. I'm probably being blocked out now. Patient comes in. Actually, patient's husband comes in about 2 months ago. He needs major work. I don't even know how he was referred. We checked to see how people were referred, but I don't remember how he was referred. I then saw his son, who's 17 years old, for an examination because the family wanted to see our office, wanted to have the family come into the office. So I'm see the son first, and then I see the mom. And the mom's probably, late 40s, maybe middle 40s. And so I did the examination. She needs no care at all. I mean, set her up for cleaning. She's brushing her teeth too hard. That's all that's going on. And she said, I want you to know something. I want to tell you a story. She said, the reason I came to see you and the reason I sent my husband to you is because of the way you treated my father many years ago. She said, you probably don't remember me. And I was only in there once with my father. My father was a big time engineer. He was producing tremendously for the major firm in our area, and he started to lose it. He lost it mentally. He had Alzheimer's, or was a special kind of dementia. And I became his caregiver for 10 years. So by the time you saw my father, he wasn't working, and so you examined my father, and then you took me aside and you said to me, let him enjoy his life. In other words, I said, don't do any dentistry. That things had gone on. Obviously, he wasn't in distress, and he didn't care about the way his teeth looked. And she said, you could have charged me $5,000, whatever it was. For whatever, I would have paid you whatever you told me, and you said, let him enjoy his life. At this age, those those are good feelings to have, and certainly results in patients being referred to you. So if you don't think it makes a difference treating somebody the way you would want to be treated, it does. And I know there are a lot of younger people who are watching this, whether they're watching this on YouTube or they're watching it live right now. But there are advantages to saying no treatment. And that's just one of them. It's one of those things where the reputation improves, you get more and more known, you're known for doing the right thing, and it does come back. I know you're all doing the right thing. I also know you have big loans to pay, because I didn't pay $100,000 a year to go to residency or to go to dental school, So I know, but it will come back. You're building your reputation right now, and it will make a difference. All right, enough of that. So let's go to session today. Okay, so this is an anterior case, and this is a case that came in this week. Okay, so intake call. So first is Amy took the call. The patient has crowns. You even mentioned where the crowns were, 6, 7, 8, and 9, because we wouldn't. Amy wouldn't know the tooth numbers. Amy is not. She's not a dental assistant. Although Amy probably by now does. One is broken. He's interested in an implant. So he wants an implant to replace the tooth that's broken. And he's scheduled on Monday, November 2nd. Okay, so I make the doctor call. The doctor call is something that we'll do for every patient sometime before the patient comes in. Sometimes I'll leave a voicemail. Sometimes I'll just make the doctor call and talk to the patient. So he tells me he's had upper crowns for 6 years. One is broken. That's the number 8. Number 7 and 9 are loose. He's grinding his teeth at night. He asked whether 2 implants can be used to replace 4 teeth. I said yes. We also talked about night guard to help reduce the forces. He also wants to replace a missing number 19. So he's already dentally aware. He knows what he wants. And by the way, the crowns having been there only 6 years, that is the reason that he's now calling us, because of the perceived expertise that we have through our PR and our marketing. Sure. Okay, so now the patient comes in, the patient sees Joy, and Joy is there for the new patient examination, takes the CT scan, takes the full mouth series of x-rays, and takes the photos. I'll show you those. In a moment, he has no allergies, and he is here to see what options he has for the upper anterior, and he's lost the crown number 8. So Joy has gotten the same information. She'll often repeat the information back to him so he doesn't feel like we're not communicating. Now, Joy will then come upstairs, which is where my office is, where I am right now, and she'll brief me, or she'll call me and say, here's what's going on. She lets me know what the conversation was. Joy will also let me know what she thinks the treatment plan is. Yeah, Joy does treatment planning. Everybody in the office is treatment planning. Every financial arrangement assistant does treatment planning. They may not be presenting the treatment plan to the patient, but they're certainly talking to the patient about possibilities. So if there's a question, should assistants be treatment planning? You're darn right they should. Don't let them paint themselves into a corner. Don't make them into diagnosticians, but certainly get their thinking going, because once they get their thinking going, then they act as a substitute for you, so you don't have to spend as much time at the chair to get the case closed, okay? And so that's important. Joy establishes the initial relationship. So does Laura, so does Jennifer, so does Danielle, any of the people who will see patients on an initial basis. Courtney is a trained dental assistant. She's our lead dental assistant. Everybody will do the same thing. But I have my 3 financial arrangements assistants who allow me to see 19 or 20 or 21 patients in a 3-day period, Monday, Tuesday, and Wednesday. That's what their job is to assist me as I see the bulk of the new patients. And many of you know I don't do anything else but see new patients, which is fine. It's good. The younger guys like it because I'm seeing the new patients, and this guy likes it because I don't have to break my back anymore. Okay, blood pressure's a little bit high, blood pulse is 92. So there he is. I don't know if that's much of a smile. I'm sure he could smile greater than that, but you can see what it looks like. Okay, now the retracted view. And you'll see fistulous tract right here. So there's something. You'll see erosion right here. Here's the tooth that's broken off, obviously. I don't even know why I said that. And you see what the teeth looked like, at least what those crowns looked like when they were put in 6 years ago. You've also got some indications of something like this here, which I believe was also done 6 years ago. And you've got some indications of that right there. What? Impingement upon the attachment apparatus, right? So you've got some indications of some things going on, and he knows that some things are going on as well. All right, so let's look at the full mouth series, and I've got this on video, so let me just click the video. So we can see that, and hopefully that will get you. Yeah, there it goes. Okay. So now we look. Every tooth that's not touched is doing just fine. It's the teeth that touched that have been touched. You've got an apical abscess in tooth number 7. Okay. Surprise the patient. He didn't know that. Okay. There's number 8. That had endo done, and we'll talk a little bit about that and how to show patient that. Open margin on tooth number 10. Look at that. Okay. Go through and everything else. There may be a little shadow there. There may be something in the mesial tooth number 12. We'll go back to 14, 15. Okay, there's the edentulous space. So he already knows he wants a tooth down there. So he comes in essentially dictating, telling me what he wants. Apical abscess in tooth number 24. He didn't know that. Take a look at the open margin on number 27. Okay, so there's some significant problems in the way the dentistry was done. So nice to be in an independent position. Okay, I don't have to cover for anybody. I can tell the patient what I see. And sometimes, if you want to talk about what develops trust, is when you can be as direct with the patient as you need to be in order to be able to tell the patient what's going on. So there we go. So that's that is the FMX. Let's take a look at the next thing. Okay, so let's look at the CT scan. Do we take a CT scan on every patient? Those of you who've been with me for a long time know we take a CT scan on every patient. Yes, we do. Because there are diagnostic elements of the CT scan that you can't get anyplace else. And if you want to look like a director of dentistry, which is what we're recommending, then you've got to act the part. And that means you're providing diagnostic tools that nobody has ever provided before. So now when we see this apical abscess, we see not only is there an apical abscess, but now it's busted through the buccal plate, hasn't it? Okay, and there's your root canal number 8. That's doing pretty well. Now we continue and we go to number 9 and take a look at what's on number 9. You didn't see that in the BA, did you? But apical abscess on number 9. So the, although we did see that in the photograph because we saw the fistula coming from 9. And there's number 10, but we also know number 10 has an open margin. Okay, are these teeth restorable? Yeah. Does he have a high lip line? No. Does he need to have dental implants? Maybe there are 2 different treatment plans we ought to be talking about. The one that he wants and the one that allows us to save teeth. Because then we're able to give him options. It's important. We've got to be able to tell the patient what's going on. You see, we go across and here's the edentulous space. I measured a little bit this morning. I was a little bit too far distal, excuse me. But we're able to measure to assure the patient an implant can be placed. So horizontal bone is about 11 millimeters. Vertical bone is about, what, 14 millimeters, 15 millimeters. All right. Once I discovered that mistake, I didn't want to redo the video. So I moved the cursor forward a little bit to be in the middle of the space. And there you go. So anyway, you're showing the patient that. We'll show the patient all of the things that the patient needs to know in order to be able to see that, in fact, there is enough bone for a dental implant. And for them to see that makes a big, big difference. So we'll go across and you'll see there's the fixed bridge. We already talked about the fit of the fixed bridge. And there's our apical lucency on number 24. Yeah, there it is. Okay. Yeah, stop. Broken through the labial plate as well there. We'll continue a little bit farther forward, and the rest of it is looking okay, at least from an apical perspective. And that's fine. Now we go to number 28, 29, 30. You know, you want to call it widening the periodontal ligament space. You want to call it something else. I don't know, but we are certainly seeing a widening the periodontal ligament space there. And we saw it on the PA as well. I didn't mention it on the PA. Okay, so that's our picture. So let's go to anatomage. Let me go to a new share. Love anatomage. And by the way, this is version number 1. I looked at the software on version 2, 3. They probably had four different upgrades. I stayed with version number 1. You can't even get version number 1 anymore. You can put Pontics in all the other versions. You can't do it on this one, but I just got used to this one. It's working for me. And so we placed an implant here in order to be able to show a patient what would happen if we place an implant. Notice the implant would be in an area that's very dark. And of course, if it's dark, as we're telling the patient this, we're telling the patient the story of what happened here. There was an infection, or there is an infection. The infection is driving bacteria from the crown all the way through the root, and pus is exiting through the end of the root, and it's dissolving the bone. So if we're going to do implants, it's going to be it's going to take longer for us to do it, because I won't put an implant in a site like this. You know, we don't want to take a chance, particularly in an aesthetic area. And frankly, even with a 15 millimeter implant, there's no apical bone for the implant to go into, but I don't want to take a chance like this. I know some people do. I don't. That's up to them. That's up to you. That's up to me. And then here's the implant that would be placed in the number 10 area. Now, I'm going to show you something here. Let's take this implant and put it in the number 8 area, okay? Now, I won't take all the time I need to get it perfectly. Get it perfectly, get it perfect. All right, so move it over a little bit. And notice we could put an implant in the number 8 site. And let's assume that we decide to do all 4 teeth, which we've got to do something about these 4 teeth, right? We do. We've got abscess on number 7 and 9. We have number 8 broken off, and tooth number 10 has a crown. If the crown on 10 doesn't match the crowns on numbers 7, 8, and 9, he's not going to be happy anyway. So we've got to do something with these 4 teeth, right? No way that we can get away without doing that. And so we tell the patient that the porcelain's not going to be the same. We've got to do all 4 teeth, okay? Declarative statement. Also telling the patient what will happen if you do. If we do only 3 teeth, we can do it, but you're not going to like the way it looks. So we have a problem with the fit of the crown on number 10 anyway. And what about the cosmetics? I mean, why did you get this done in the first place? Cosmetics. We're not going to get the teeth to match. So we've got to do all 4 teeth in one way or the other. But let's assume we decide to do a fixed bridge. Okay, let's assume we're going to do it with an implant. And he's already saw the number 7 has very little bone. What about putting the implant number 8? You can put an implant number 8 and number 10. In fact, Dennis Turner a few years ago lectured on that. Put an implant in 8 and 10, cantilever number 7. There's absolutely no reason why you can't do that. So if you've got better bone in number 8 and you're under the gun and you want to take out number 8 and you want to put implants in right away on a low lip line, good. Put implants in numbers 8 and 10 rather than 7 and 10. You got it. You'll have what you want. High lip line case. Oh, then we talk about gingiva. We're going to talk about smile line. We're going to talk about all of those things. That's not what we have to worry about here. Okay, so let's go back to the CT scan a little bit. I'm sorry, let's go back to PowerPoint. Okay, so we're going to anatomage. Okay, so now are the examination notes. And we're doing a comprehensive examination in every patient. I don't care if the patient's in for free gingival graft on tooth number 24. The patient is getting a comprehensive evaluation. How much time do I spend at the chair? Half hour. Assistants are doing everything else. Assistants are there for 2 hours. So intake is about 40 minutes with the assistant taking all the x-rays and taking the photographs and doing the CT scan and FMX and all those things. Then I'm on for 30 minutes, and then the assistant is taking over the entire treatment plan to explain what I said. Doesn't mean I'm not going to give an overview, but there's going to be some confusion, particularly if I'm offering 2 different possibilities. But the first thing we want to do is to make sure the examination is complete, and the way we make it complete is to make sure that we have a checklist covering every aspect that needs to be covered. I covered this last week, but for those of you who weren't here. Okay, head and neck examination, angles class 1, Fremitus number 710, overbite 50%, overjudge 0, crossbite no, and the patient is admitted Bruxer. I'd say the attrition is moderate, abfraction that's not there, erosion that's not there, TMJ is okay, or I might say late reciprocal click on the right side or something like that. Maximum opening with a TMD wedge that you get from Shine, or there are a number of different places you can get it. 41 millimeters, Mallampati score. Do we use it? No. The anesthesiologist might use it. It's one more sign. It's one thing that we can give to the anesthesiologist to let the anesthesiologist know what's present. But Mallampati score takes 2 seconds for the patient to stick his tongue out and let us know, and we can see the Mallampati score. Palatal vault is normal. Why do I want to know that? Because many of our patients are coming in for full arch something, and if they get a full denture, I want them to know they have a flat palatal vault or they have a palatal-torus, and that in fact the denture may not work as well. Gingiva is firm. Take a look at the periodontal probing chart. Not much until you get around 24 and 25. But remember what we saw there, 23 and 24. Remember what we saw there, impingement on the attachment apparatus. And maybe we'll draw a picture of impingement on the attachment apparatus in a second. So we'll talk about what that is. So the patient has a full understanding as to why that swelling will never go away. It makes a difference. So I'll draw that. I'll draw something just so you can see the benefits of drawing in front of the patient. Okay, exam notes, still the assistant. There's bleeding. It's moderate and lower anterior due to an ill-fitting bridge. And sorry, we didn't spell ill correctly. Calculus light is black. Black is light. Okay, so the problems that I'm stating in front of the patient, and I want the patient to hear every problem, every single problem. Okay, so number 6 has root erosion. Number 7 has an abscess, has an open margin, has decay, an ill-fitting crown. Patient has had endo, however, the crown broke off on number 8. That's the reason he came in. There's an abscess, a trapped infection between the bone and the tooth, between the bone and the root on number 9. Number 10 has root erosion with an open margin on the lingual, checking restorative as well. Number 19 is missing, was extracted about 12 years ago. Number 24 is an abscess that's eating through the bone on the facial. Eating through the bone on the facial. Okay, let's make sure that the words that we're using are words that the patient can understand. Okay, number 23, 24, and 26 have ill-fitting crown, and I find out the endo on number 30 was done by an endodontist in our area. So there's an ill-fitting bridge on lower anterior, number 21 through 27, bleeding gums, and one thing we have to do is endo if we're going to save that bridge for as long as we're going to. And then if number 24 fails, then do a root resection. So these are all of the things that I'm saying fairly quickly to the assistant that the patient is overhearing. I fully assure the patient that we're going to explain this in detail afterwards. I'm just trying to get everything taken care of. What is the patient here? Patient hears problem. And I'm not making up the problems, am I? This patient has problems. So we're talking about the problems so the patient has a better understanding that there are problems and we're going to have to come up with solutions for every one of those problems. Now, sometimes the patient may not choose to take all the solutions. That's fine. We've got to spell out the problems and the solutions and let the patient know the consequences of what occurs when he does nothing, some, or all. And by the way, some of these things can be delayed. We don't have to do everything all at one time. And if we can do that, we let the patient know that we can do that. That's all part of a comprehensive plan. Okay, so now with all the problems, what does the patient tell me? He tells me that he's selling a rental property in order to get his treatment done. He wants a more permanent option. I explained to the patient the difference between trying to save the teeth and doing dental implants. So we talked about what we could do with 7 through 10. And we talked about dental implants. We talked about the 2 different options. Okay. Treatment plan, recommending a water pick for lower anterior to help with the bleeding. We can't do anything about the impingement on the attachment apparatus. Once we take off the bridge, we redo the whole bridge. Well, that may not be something he's ready to do right now. We got to do endo on number 24 in order to be able to save that tooth, knowing full well that when we do endo on number 24, the tooth may break off. I think I'll show you that. And then number 19 needs an implant above and a crown. Okay, so first thing he wants to do is get that tooth replaced. So we make a tooth color to Essex on number 8. If you can provide that patient with immediate treatment, okay? Maybe the general dentist says, I'm booked up for 2 weeks, and you can provide immediate treatment. You have a vacuum form system where you get some denture teeth, you can put it in there, and you can give the patient a temporary. Great. If the general dentist is going to do that, that's great. We've got both under one roof. So essentially, we've got to get the patient happy as fast as we can, and he doesn't want to run around with a hole in his mouth. But when I was just a periodontist, we didn't have a full service practice, we'd make temporaries. Patient said, I can't get into my dentist for a couple of weeks. I'll do it for you. Okay, what do you think that does for the patient and for the relationship between the patient and me? And then we talked about the next step is do endo 24. And then remove crown number 7, 9, 10. So all of the things that we talked about now, Joy is putting it into a sequence of treatment. Joy's doing this based on what I'm telling her. So she's developing the sequence. Or we take the implant approach. And if we did an implant approach, here's what we do. We extract number 7, 1 unit. 1 unit means 10 minutes. Okay, it'll take us 10 minutes to extract that tooth. It's 1 unit means 10 minutes, and 1 unit also means this is the charge for this procedure, because we might have a 2-unit extraction. And a 2-unit extraction might be more complex, might take longer, and we might have to charge the patient twice as much because of that complexity. So we're scheduling both the time as well as the fee just by saying 1 unit or 2 units or 10 units or whatever it is. Okay, so extract number 8, 1 unit, 9, 1 unit, 10, 1 unit. We're going to put a large membrane, number 7 through 10, because of the abscesses on number 7 and number 9. Okay, and then we'll use 3 Minoros and bone graft, and we'll have to build a facial bone in number 7 and use a membrane for that, because the facial bone is almost gone. So we'll use a membrane. So bone graft number 7 will be 6 units. So you get all of those things. Okay, sorry, I'm getting text. Okay, then we'll wait 4 to 6 months. Then we design a surgical guide for 7 and 10. We place implants number 7 and 10 with a new Essex, and then we place the abutments and crowns when they're ready for uncovering. And by the way, I mean, number 8 is a possibility too. So there's 2 different options for treatment. Even with the amount of time that Joy spent with him, she met with him again 2 days later because they ran out of time. They just ran out of time. He was busy, she was busy, whatever. She couldn't get it all done. And so he came in yesterday. He said, all right, I've decided to do the implant approach. And he wrote a check. I think it was, I forgot, something, $15,000, $17,000, and wrote the check for the entire thing, all at that one visit. And yeah, you can do that. So you're not worried about accounts receivable. And so how do we do that? Essentially, we say to the patient, listen, you need the treatment. We have to order some supplies. There will be a certain discount if you pay for it all at one time. Would you like to take advantage of the discount? They also have the choice between using one of the credit companies like Green Sky or Care Credit or something like that, or they can pay for it within 2 weeks of the visit, and even within 2 weeks of the visit, we'd still give them the discount. But he was ready to pay. He paid. Okay, and we gave him the Essex right away on that day. So might a drawing help the stories? Help tell the story. So let's do drawing, and I'm going to do the best I can in working with this system. So let me stop share here, and let me share here. So yeah, go liveboard.com. So I do this with a pencil and paper. So what do we talk about? We talked about, the tooth breaking off. Let's even talk about the upper tooth breaking off, because I can draw an upper tooth. So let's draw an upper tooth. So there's a nice central incisor. It doesn't have to be pretty. It can just be what we want. All of us know how to do this diagram, or if you don't, learn the diagram. It's an important diagram because this is the bone right here, and I know you know that. I'm telling the patient that. And, the tooth isn't held directly into the bone. The tooth is held into the bone by a ligament. It's like a hammock, which holds the tooth in place. And surrounding that is the gum tissue, which in health is attached to the tooth. So there's the picture. Well, let me tell you the story about this tooth. We're talking about the story about tooth number 8. The one was endodontically treated, right? Okay. So here's the story. You had a cavity in that tooth at one time, right? Yeah, you had a cavity in that tooth. All right. So the dentist had to drill a hole like this. And usually if you have a cavity on one side, you have a cavity on the other side. So the dentist had to do something like that. Yeah, I remember I had some fillings done here. Okay. Well, what's going right near here? Right, going right here is the nerve of the tooth. We call it the pulp. But the nerve of the tooth is a little hollow channel that's going right through the center of the tooth. I'll make that a little bit thicker for you. So what happens ordinarily is that we can get decay. You know, you put a filling in, filling does not stop decay. It will remove the decay, but if you're prone to getting decay or eat sugar or something like that, you'll get a new cavity right here. And sometimes that cavity will come very close to what? The nerve. And so you've got bacteria that's flowing into this area here. And you don't know it. You know, sometimes you don't know it until it's too late. So here's what would happen. So now the dentist puts a hole through the tooth right here. Why? Because the dentist, the endodontist, has to get the nerve out of the tooth. And so they'll go in through that hole in order to be able to get all the bacteria out. And so they'll go all the way through this tooth, and they'll remove this nerve, which is now probably a dead nerve, but there's still a hollow tube there. I'm going to draw the hollow tube in a second. So now the tube is like this. Okay. So what do you have left? You've got, this is a hollow tube, and by the way, this is filled up with a filling material. It's a rubbery material. It's called gutta percha. I was putting it in air like this, and that's what I see. Now this tooth broke off, right? I mean, this is the one that's broken off. This is tooth number 8. So what happened? Well, what the dentist did was to prepare the tooth for a crown. Okay, so let me show you the crown preparation, the way it looked. And we'll take away all this old filling material. Although often some of the old filling material is left under the crown. Sometimes we'll use that for something we call a buildup, a core buildup, so we don't have any undercuts on the tooth. But that's where we are. I'll get rid of this bacterial thing because that doesn't apply here. Okay, so there's our nice hollow tube. Okay, so now what happens? So now the dentist prepares that for a crown, makes an impression, and makes you a crown for the tooth. Okay? But what's this crowning? It's crowning a hollow tube, and look at how thick this tooth structure is. Not very thick, is it? Look how thick this tooth structure is. All you have to do is get a little bit of a fracture. And by the way, root canal treated teeth are pretty prone to fracture. And now you see what happens? It just cracks off. And that's what happened. I'm doing this with an eraser, with a pencil and an eraser. I'm not doing a fancy, whiteboard that's electronic, although maybe I will. I like this. So now you have this picture. Imagine a patient saying to you in another scenario, well, he ground my teeth down to nubs because the patient saw whatever that was and put crowns. How come? And my crowns fell off. So we can show, why would the crown fall off of this? And why might we need to do crown lengthening in order to be able to take care of this? So let's just do a crown lengthening exercise. Okay, so this tooth needs crown lengthening. Why? Because this tooth right here, there isn't enough tooth structure to hold on to the crown. And so what do we do in crown lengthening? We make an incision in the gum line. We peel the gum tissue back. I didn't know you can enlarge this. It's kind of good. And what we're going to do is remove enough bone support like this, along with a ligament. So what? So that we can have enough tooth structure above the gum line. There's the bone. And now the gum, rather than resting here, now the gum will rest. Give me a second to get this all done. Because the patient is watching me intently as I'm doing this. They've never seen anybody do this before. So now we get all done, the gum tissue will rest here and here. And now, let's take this crown away for a second. Now we've got enough healthy tooth structure above the gum line so that now we can prepare the tooth correctly. We might add a little core here. And now we can put a crown on the tooth that way. And now the crown has something to grab onto and it'll stay. So we tell the story of the tooth first, and when we tell the story of the tooth, then we show the weaknesses in the tooth. You could use this for impingement upon the attachment apparatus. You can use this for routine perio, whatever. You tell the story of how the patient got there. And the patient sometimes will be amazed that you knew the entire story of that tooth. So it's a useful exercise, something that that you can use in order to be able to help the patient understand what's going on. Okay. So, might a drawing help to tell the story? If you're not doing drawings right now, I don't do it all the time, but do it. Then the next step is to dictate in front of the patient. Yes, I know there's all sorts of software which allows you to bypass the dictation step. Don't. I dictate right into my phone. We've talked about this before. Smart Recorder is a great app. I dictate into my phone. I talk about the entire situation. Why? Because I want to tell the story. I want the patient to understand what's going on, and so I want to dictate in front of the patient. So the patient presents for evaluation. He has a fractured tooth number 8. Crowns replaced on number 78910, as well as fixed bridge 21 through 27 about 6 years ago. This was to correct a bite which was placing trauma on the teeth. And I might even look at him and say, did I get that correct? He says, yes, okay. So then we talk about impingement upon the attachment apparatus, which I've already talked about, on the distal aspect of the fractured tooth. And I try not to put in words that are not understandable, but sometimes if I do, at least I've explained it to the patient before I've done that dictation. There are apical abscesses, number 7 and 9. There are open margins of several of the upper teeth. Number 24, there's an apical abscess in the number 24 area, and number 19 is missing. There is no other pathology present. The question is whether we should save the upper teeth or whether we should extract them. That's what the patient has in his mind, because I've explained 2 different treatment plans. Okay? And remember, he came in because he only wants an implant in number 8. Remember, that was the reason for his call. Now, we found a whole lot of other things that he can't just ignore. So now he's putting the whole thing together. There is an advantage of saving the teeth, but I would not know whether they are savable and what work would be necessary until we remove the crowns in number 7, 9, and 10. If we decide to save the teeth, the sequence will be the following. Let's create an Essex that replace number 8 as an emergency procedure. Have another Essex ready to replace number 7, 8, 9, 10. On the day of treatment, remove the crowns. On 7, 9, and 10, determine the restorability of each of those teeth. Place the Essex at that particular time to replace the missing teeth. Okay, the patient's hearing every bit of this. Refer for endo on number 7 and 9, presuming number 7, 8, 9, and 10 are restorable. Okay, and I'm not sure until I take this off. It's just like a remodeling project. You're not sure what the plumbing is like and what the wood is like until you take off the drywall. Okay, or if you're up northeast, sheetrock. Okay, do build up in temporary crowns, number 7, 8, 9, 10. Post and core will likely be necessary, number 7, 8, 9, in order to be able to do that. By the way, do you know that sheetrock is only a brand name of drywall? Anyway, let's get back. Crown lengthening, root reshaping, number 7, 8, 9, 10. Wait 3 months, and final crowns, number 7, 8, 9, 10. That's treatment plan number 1. If we take the implant approach, will be the following. Prepare an Essex, replacing number 7, 8, 9, 10. On the day of treatment, extract 7, 8, 9, 10. Do bone grafts as necessary on number 7, 8, 9, 10. Membrane may be necessary in the facial aspect. Number 7 and 9 will be able to take care of that area. Given the fact that number 8 has already been endodontically treated, I would prepare to treat with a large membrane crossing numbers 7 through 10. Place the Essex. Wait 4 to 6 months. Take a CT scan. Utilize the best bone, either number 7 or number 8. And number 10 for fabrication of a surgical guide to place implants in the upper anterior region. An implant placement, wait 4 months, then final construction of the fixed bridge with custom abutments numbers 7 and 10, and a fixed bridge numbers 7 through 10, or numbers 8 and 10 with a cantilever fixed bridge from number 7, from number 8 through 10. Simultaneously, the upper and endodontic procedure should be done in number 24 and a lingual composite. Note there's impingement upon the attachment apparatus throughout the bridge, number 21 through 28. At this point, I would not recommend replacing the bridge. I would recommend that Bill use a water pick and do the best that he can with the impingement upon the attachment apparatus. Finally, and this will be done simultaneously with the upper arch, place a freehand implant, no surgical guide, number 19. With a custom abutment and crown, Leon Sheldon DMD. That will, now, don't forget, most of my career was a referral practice, right? I wrote a letter like this every single time to the restorative dentist. Imagine how much time it saved the restorative dentist. And if you're preserving the referral relationship, which I don't discourage, imagine if you were able to give the patient the entire fee right in your office. That's being the director of dentistry as well. So now you've written a sequential treatment plan. Now, it doesn't mean the general dentist can't change that treatment plan, but you've established a sequence. The patient's gotten all of the answers from you because the patient has to get all the answers from somebody. It's either the referring dentist or you. Okay, so you can decide which it's going to be. I'm going to suggest that since you're going to go through a detailed treatment plan just like you did, that it ought to be you, and let the general dentist take advantage of that, because the general dentist doesn't have to, in quotes, sell any dentistry. You've already talked about the needs, the health needs, why it needs to be done, and the different options that are there, along with the fee. So the patient can work with your financial arrangements assistant to arrange for financing. They know that the total treatment plan is going to be $18,000, whatever it is. And you can say, well, $9,000 is going to be here, $9,000 is going to be in the other office. I just wanted you to see the entire picture. Then the patient's not confused, and then the patient's more likely to accept treatment. So let's stop share for a moment. Are there any questions? Anybody have any questions about anything that we just said? Any comments? Okay, I see none. If you do have questions, just write to Lee@directorofdentistry.com. I'll be happy to answer those questions if I can. Otherwise, I'll cover them in next week's webinar. If you like the webinar, please tell others. And I'll be with you again next Friday at noon Eastern Time. Thanks. Have a great weekend. Oh, I've got a question. How did you figure out how to quote the fee for referral practice? And the answer is, that's a good question. Generally, I know what fees are. In other words, if I'm looking at a 4-surface filling, I know what fees, what the fees are. Now, there may be a range of fees. You know, some general dentists might charge $100 a surface, others might charge $80 a surface, whatever it is. You can start to get a feeling for the range of fees. What you want to do is to quote the highest fee. Why? Because the patient goes back to the general dentist and you said it's going to be $100, and let's say $400 for the buildup or whatever it is, and it only costs $350. How does that dentist look in the patient's eyes? See, you've quoted what you think the maximum fee could be now that dentist has just saved $50. So yeah, you should know what the standard post and core fee is. You should know what the standard buildup fee is. Should know the per surface fee on composites. I mean, there are basic fees that you should know, and that's what you put together for the patient. It works out very, very well. Always worked out very well for us when we're still a referral practice, a smaller referral practice. Most of our patients are coming directly to our office, and we still do that for everyone. So you might want to get together with your top 2 or 3 people and say, what are your fees for this? Give me the general things that you usually see in the office, because I want to help you by talking to the patient about what the restorative dentistry might be. In fact, if you want to let me know what the restorative dentistry is, I can at least give the patient the total fee so they're not surprised. Would you like me to do that for you? Most every dentist will say yes. Some will say no. But most every dentist will say yes. Hope that helped you. You're welcome, Jessica. Anybody else have any questions? All right, good. I will see you next week, noon Eastern time. And let's continue to have a good time. Let me know what you need. I'll be happy to help. This is now my Friday morning. I get the case ready on Friday morning, and I'm doing this for fun. And by the way, I just ordered some new lights, so we'll see if we can get the lighting a little bit better. I'll see you next week. Thanks. Bye-bye.